Hello, I'm Dr. Christopher Thompson, and I'd like to provide you a review of intralymphatic immunotherapy, trying to answer the question, can 3 injections replace 3 years of allergy shots? I'll cover the biologic rationale, the clinical evidence, controversies, future directions, and talk a little bit about our experience with intralymphatic immunotherapy at Aspire Allergy and Sinus. So the first question you might ask is, do we really need another form of immunotherapy? And I think our experience with compliance rates with SCIT and SLIT would answer that question quickly. We have very poor compliance. Most studies show a compliance rate less than 50% and maybe even around 20% for sublingual immunotherapy. We only treat fewer than 2% of patients in the United States who have significant allergic rhinitis disease. And I think that those two variables are directly related to one another. The compliance is difficult. Consequently, we have few people who choose to either start the therapy and certainly finish the therapy. The biologic rationale for intralymphatic is pretty straightforward. It really isn't that different from what we've been currently using. With SCIT therapy, as you know, we deliver it subcutaneously with the hope that some of that will end up into a lymph node, into a regional draining lymph node, but we know that most of it doesn't make it there. Most of it's destroyed by the local immune system. SLIT follows the same pathway, but with intralymphatic, we're going directly into the lymph node. We're visualizing it with the ultrasound, so we know it's going in. And actually, as you'll see later, there was a study that looked at effectiveness compared to how well the antigen was delivered, and there really is a relationship between getting it directly into the lymph node, not next to it, but directly into it, and efficacy. So potentially, if we can deliver it to the lymph node directly, we can deliver a much smaller dose because we know we're delivering tiny microscopic doses when we use SCIT and SLIT. We think fewer administrations might be necessary, that we'll see a more rapid antigen presentation and more rapid reduction of systemic allergen exposure. And of course, the holy grail is the induction of tolerance, long-term durable tolerance. So what does an islet involve? Well, as I mentioned, you use an ultrasound probe that will easily allow you to visualize the lymph nodes in the inguinal region. Most studies have used the inguinal. There have been some that chose cervical. The classic protocol is 3 injections at 4-week intervals, so on day 1, day 30, day 60, so it's a 2-month treatment. The study that really put intralymphatic therapy on the map was this 2008 study by Senti. The reason it drew attention was that rather than just postulating a mechanism, she looked at 66 patients receiving islet therapy over 2 months and 99 patients receiving SCIT therapy over 3 years. And the results were remarkably similar between the two groups. They all had significant improvement in nasal allergen tolerance. With islet, that was within 4 months. They all had improved hay fever symptoms. They all demonstrated significant improvement in skin prick test reactivity. They had decreased GRAS serum IgE, reduction in the need for medications, and general quality of life improvements. The other important finding, of course, was that safety was comparable between the two, and that islet actually produced fewer adverse events, and it was considered less painful than venipuncture. Obviously, the islet patients received a dramatically lower amount of overall antigen delivery. but had similar outcomes. The outcomes turned out to be durable too, because as you might imagine, the islet patients were done after 2 months, and the trial was completed after 3 years. So the islet patients were still significantly improved at 3 years. One caveat with this study was that although it was randomized, patients were randomized to either islet or SCIT, it was not blinded, so there wasn't a placebo arm. So that Senti study called into question the idea of the need for the accumulation of antigen over a period of time. So it looks like that may not be the necessary feature, but the amount that's actually delivered to the lymph node. So how much allergen is really necessary? Because we know for years we've been using kind of a slow delivery mechanism, accumulating a lot of antigen over years. But the difference in the delivery systems here may still allow for good outcomes even when a small amount of antigen is delivered. And I say small amount, but that's really relative, because islet tends to use about 1% of the SCIT maintenance dose, so a very small fraction. But because we're bypassing the normal delivery pathway, which probably only delivers 1/1000th to 1/1,000,000th of soluble peripheral antigen into the draining lymph nodes, that 1% really translates into potentially 10 to 10,000 times the amount of antigen that actually would reach the lymph node. So in other words, the traditional SCIT mechanism delivers such a small component of the original dose to the draining lymph nodes compared to a smaller islet dose, which delivers 100% of it. So in the end, there's a tremendous increase in the amount of antigen that is delivered to the lymph node. And that's probably the mechanism by which the islet therapy can provide durable relief in some patients and do so in a very rapid fashion. As I mentioned in the earlier Senti study done in 2008, it was an open label trial. Although patients were randomized to either islet or subcutaneous, the patients and the investigators knew that they were getting active drug. So that was one criticism of the study. So her next study in 2012 was randomized and double-blinded, so that they introduced a placebo control. And in this one, they used cat, and they used a recombinant cat allergen, which was new at the time. And the outcome of the study was predominantly based on nasal tolerance. So they delivered cat antigen nasally through an aerosol and found that patients who had been treated with the active islet therapy had a 74-fold increase in their nasal tolerance. So an enormous improvement in their ability to be challenged with that antigen. They did look at some immune markers. Treg cells were notably increased, and they also found that cat-specific IgG4 was increased as well. So they found immunologic markers and as well as the clinical improvement. This next study was also a double-blinded, randomized study with a control looking at GRAS antigen. And they also used the traditional intralymphatic method over 2 months, and they looked at patients over 3 years to see if the symptom reduction was durable. What they found was that at 3 years, they had a 48.5% median reduction in combined symptom and medication scores compared to the placebo group. Interestingly, they also introduced the concept of a booster that was delivered at 1 year. So they had a third arm of the study that received the same intralymphatic therapy, but also got a booster injection. They didn't see any improvement with that group who received the booster. The really interesting thing about this study was they also looked at how effective the therapy was relative to the successful deposition of antigen in the lymph nodes. So they graded themselves on how effectively the injection was performed after each injection, and then watched those patients and found that there was a correlation between the patients who received good injections with visible delivery of the antigen into the lymph node versus those patients where the antigen appeared to have been delivered next to the lymph node. That was a really intelligent thing to look at, because one of the biggest questions that we have in islet therapy is, why doesn't it always work? And I think one obvious answer to that question, although there may be others, is that if the therapy isn't delivered properly into the lymph node, you're not going to get the same results as you would otherwise. This next study by Helkvist in 2022 looked at pushing the envelope with dosing. And they actually did 2 different studies, the first of which looked at patients who had already received 3 years of subcutaneous immunotherapy, and this was for grass allergen. And those patients ended up receiving 3 intralymphatic doses at 1,000, 3,000, and 10,000 SQUs. You may remember that the traditional method uses just 1,000. So they pushed the envelope significantly with these patients, and the patients tolerated it well. Remember, these are patients who had already had subcutaneous immunotherapy. What they found was in these patients, and a lot of these patients were recalcitrant to the prior therapy. They didn't see as much improvement as they would have liked, and these patients saw a combined symptom medication score improvement of 31%, and their grass-specific IgG4 approximately doubled. So they were encouraged by these results and thought that maybe in grass antigen naive patients, they could use a similar dose escalation of 1,000 to 10,000, but they were not able, those patients weren't able to tolerate the 5,000 unit level. So they modified the protocol, went from 1,000 to 3,000, and then did another dose at 3,000, and they did not see similarly good outcomes. They did see some indication of immune activation by sampling cells from the lymph nodes that they injected and running them through flow cytometry, but they didn't demonstrate T cell activation. So it appears that something about that dosing protocol did not produce the same kind of results as the traditional 1,000 SQ units had previously. So the next logical escalation of these trials would be to add another antigen, which is what this one did, using birch and a 5-grass mix. This paper was published in 2023, and interestingly, they used the traditional protocol, but they delivered the birch on one side and the grass on the other with separate injections. Their initial outcome was disappointing because they really didn't see improvement in quality of life or symptom medication score. Now, the authors did note that the baseline season for which they developed their comparison was much lower than normal. The pollen levels were much lower. Specifically, the birch pollen was lower. So they were comparing the two seasons simultaneously and thought that that could be a confounding factor. Then in year 2, the study was unblinded and they surveyed the patients again, and now they found fewer symptoms, lower medication use, and a better quality of life than the placebo group had done originally. And in particular, the GRASS results were particularly favorable. But the study was unblinded, so it does introduce the placebo effect, and so a good study, but definitely left a lot of questions. They also used immune markers, and they did see positive findings there. They saw increased Treg cell frequencies and increased GRAS-induced interferon gamma production. They did have the same good safety profile. Now, looking out a little bit longer, the study represented here examined patients at 5 to 6 years after they received the traditional intralymphatic therapy using birch and grass, as in the previous study. They were able to contact and get results for 20 of 26 patients who were in the original study, and they did a number of different tests. So they got immunologic biomarkers as well as quality of life, medication scores, symptom scores. And what they found was that the patients at 5 to 6 years had markedly lower combined symptom medication scores than the untreated controls. They did see a significant improvement in nasal provocation at year 1, but at year 5, those results did not hold up. The immunologic markers that they looked at were GRAS-specific IgG4 and IgE, as well as memory T cells, and all of those continued to be durable over the 5 years. So the patients in general had improvements in their quality of life scores, their medication use scores, their symptom scores. They had improved immune markers, but the one thing that did not hold up at 6 years, 5 to 6 years, was the nasal provocation challenge. In order to look out even further, this study went back to the original Senti participants for the paper that she published in 2008, and they were able to recover 25 of the 58 patients who received intralymphatic immunotherapy and 29 of the 54 who received SCIT. Again, this was her GRASS study, not the CAT study. And of those 25 that received islet, 4 of those, which represents 16%, were still, and this is 19 years later, were still completely protected from grass pollen rhinitis, so had no symptoms whatsoever. On the SCIT side of the equation, there were 3 patients out of the 29, so an 11%. 11% of those patients also had complete protection. So very similar results compared to between SCIT and islet, and this again is 19 years out. And if they just looked at general satisfaction, 76% of the islet patients at 19 years were satisfied with the therapy, and 79% of the subcutaneous immunotherapy patients. So very, very similar results at with an extremely long follow-up. Now again, this is not blinded. These patients knew they had been treated with the active antigen, so that's an important caveat with the story, because the placebo impact could have been present here. Now this slide refers to a study that Dr. Silvers and I did together here at Aspire in Austin, and we were really trying to do a proof of concept study. It wasn't a large number of patients, but we wanted to experiment with the impact of cedar antigen. As most of you know, cedar is very concentrated in Austin in early January and February, and we have a lot of people who get severely ill with it. So we thought it would be a fun study to perform. And so we went through the double-blind placebo route, and we followed these patients out for about 4 months after they completed, and the treatments were very well tolerated. We had no significant reactions, and there was a significant improvement in both symptoms and medication used. So of course, eyelid is not limited to grass pollen. It's used widely with most of the environmental allergens. I've listed the ones that have been studied heavily, but there are others, and at Aspire we currently use just about all of the antigens that we test for. I think the one thing that is well established with eyelid is safety. It's been studied for a long time. We've had a good selection of patients to know that it's consistently safe. It's comparable to that of subcutaneous immunotherapy, in that most of the reactions are mild. They're local with injection discomfort, which is transient. Rarely do we see serious reactions, although they do occur, just as they do in subcutaneous. And I think the conclusion is that with direct lymph node administration, we're not seeing a significant elevation of systemic risk, but we're not seeing an elimination of it either. And whether that's due to antigen that leaks out of the lymph node that doesn't make it into the lymph node, it's still not yet clear. So as you can tell, the islet trials do not all agree with one another. Some get really good results and some don't get good results, and that leaves questions as to why that might be. Clearly, allergen formulation probably has an impact. The dose, we think that the window is narrow. We think that the timing is also narrow. Injection accuracy, as I mentioned before, which was looked at in that specific study, seems to be very important, and it's usually routine, but sometimes it is difficult to get the antigen into the lymph node. Even if you think you are in the right place, you may see the antigen deliver outside of the lymph node. And as that study indicated, and we believe the same, that those probably aren't as therapeutic. Some of that antigen probably ends up in the lymph node, but you'd have to believe that less antigen will be delivered if you don't get it in. Of course, the big question, whether you're talking about subcutaneous, sublingual, or islet, is mono versus polysensitization. How do those outcomes differ? Does the immune system tolerate multiple antigens, or tolerance to multiple antigens at once? These are questions that are unanswered for all types of immunotherapy, but are definitely germane to this discussion. Environmental exposure, the seasons differ wildly, as everyone here knows, and if you're comparing season to season, it's difficult to really have a good anchor point. There's just a lot of heterogeneity in symptoms, medications. The immune markers look positive for this. The skin responses in that one study look good, but as most of you know, it's hard to count on skin prick testing as a way of determining whether the allergic immunotherapy was effective. So of course, with the individual studies that I presented, over time. They've accumulated, and multiple meta-analyses have now been done. And I've got a list of the major ones that have been done since 2020, and they all show good safety, mostly favorable, but at the end, most of them conclude that there's still a lot of questions, and a lot of the studies that weren't double-blinded and placebo-controlled don't deliver the quality of research that is necessary to answer these questions in black and white. So to review that, the 2025 overview suggests improvement in allergic symptoms and objective rhinitis measures. They seem strongest in the grass pollen and in the mixed allergen data sets. Safety is obviously favorable, but overall certainty is not guaranteed, basically because of the study quality and just the heterogeneity of allergy measurement itself. So when I look at this is kind of how I grade it. Again, this is pretty subjective, but it's got a great rationale. It's not any different than what we're doing currently. It's just more of the antigen is delivered. Patient convenience, clearly it's far superior than anything we offer currently. It definitely looks like there's demonstrable immunologic activity. Many of the studies have immune markers that were strong and consistent. We do believe there's clinical efficacy. We believe there's long-term durability, especially in the 19-year study. Again, very small numbers, hard to know for sure, but there's it seems to be a signal there anyway. Dosing and formulation, again, I think there's probably a consensus forming around how to do this, but I don't think, we haven't treated 1 million patients, so I don't know that we're there yet. And that is also reflected in this last line, maturity compared with skin slit, when we're about 100 years behind, so it may take a little while to catch up. So some of the key insights, islet may not be one treatment. It may just be a delivery platform, and you've still got to find the right patient and the right allergen, the right combination of allergens, the dosing, the right lymph node. Who knows whether that's a question or not. We treat them all equally. We think that you probably have to have accurate intranodal delivery, and that's got to generate immune tolerance to have any clinical benefit. And so here are the questions that we've kind of gone over multiple times. What's the optimal dose? What's the best injection interval? Again, I think those are pretty well defined, but there hasn't been a lot of experimentation around this. Dr. Senti's original 3-dose separated by 4 weeks protocol using about 1,000 units, SQ units, is still the standard, and most studies just use that as a default. So maybe there are better formulations or better intervals. Boosters is something that we're still very interested in. It wasn't shown to be effective in that one study, but the way that I look at it is the booster mechanism may simply be that you're getting lymph nodes, you're getting antigen into the lymph node again, and it's possible that you thought you got lymph node delivery in the past and you didn't. So maybe a booster provides that additional level of insurance that you're making more attempts at delivering the antigen. And so if you're not always successful, maybe there's a role for boosters. Clearly, the other more obvious indication is for the fact that the immune tolerance may lag after a year or 3 years or 5 years. But the jury is definitely still out on that. I know that we're experimenting with it, and we have not come to any conclusions as to what the best method is and whether it works at all. The best patient phenotype, I'm not even exactly sure. We've arrived at that for SCIT and SLIT patients. We certainly aren't there with intralymphatic. The durability, again, it's up in the air. We've got the long-term 19-year study, but it was so small. Yeah, and the last question is, can we reproduce good results consistently across centers? And that remains to be seen because there just aren't a lot of people using this clinically yet. So what we do know is 3 injections can induce measurable allergen-specific immune changes. Multiple controlled trials have demonstrated clinical benefit. Treatment burden is much easier, much lower than it is with conventional allergy immunotherapy, and safety looks great. In our experience of a little over 4,000 patients to date, we started with delivering 3 antigens, and we have since figured out how to get 10 antigens in a volume that's suitable for lymph node injection, and we've been doing that for over a year now, and still have an excellent safety profile. We have not studied our data rigorously in any scientific sense whatsoever, but we do indirectly measure patient satisfaction, and we see a 75% satisfaction rate with the therapy. We definitely have non-responders, and we have many anecdotes of people who have had complete protection from antigens. Of course, those are our favorites. I wish it happened every single time. And this last slide, or second to last slide, I think is important because we often get really focused in on what is the efficacy. I know patients often want to know, what is the efficacy? If I do SLIT, if I do SCIT, what's the likelihood of improvement? And it's easy to get caught up in that number, but really that number isn't that important, especially considering that these therapies are probably very similar in efficacy. We're not talking about orders of magnitude different. The question is compliance. And everyone in this field knows how important and how difficult that is when you're getting people to do something for 3 to 5 years. It's not hard to get somebody to do something 3 times over 2 months. In fact, I think in our hands, we're pretty close to 100%. We're probably not at 100%, but since it's a cash pay service, patients are very tuned in to that expense. They only have to come in 3 times. It's a quick visit. It's essentially painless, and the safety profile is very good. So we see the equivalent of 100% compliance with our islet program. I looked at national averages for SCIT and SLIT compliances, and there are wide ranges, anywhere from 20 to 40% for SCIT, and I've seen anything up to 50% and down to 17% for SLIT, but it looks like the national average is around 20%. And again, I don't know how good these numbers are, but I think they're probably in the ballpark. It's definitely different from practice to practice, but if you consider compliance in the real world success calculation, it really changes the way you look at this. And you start to discount the effectiveness of the individual therapies when you do this equation, because if 20% of our patients finish a course of SLIT and it's 85% successful, our outcomes are not good. We have a 17% real world success with that therapy. Same with SCIT. If 40% of our patients complete their SCIT regimen and it's 85% effective, we're only fixing 34% of patients. Then if you look at islet, if if our patient satisfaction index is in the ballpark at 75% and we get 100% compliance, we're more than double the real world success of SCIT. And you can manipulate the efficacy numbers a lot and still see substantial benefit with islets simply because compliance is so easy with that form of therapy. And I really think that's the story here, is that if we can establish that this therapy is effective and safe, and I think we're pretty close to that right now, then with multiple repetitions across multiple clinics, I think it'll be pretty clear that when you factor in the compliance number, it's really a superior therapy. Durability is still a big question, granted. There's only been that one long-term study, beyond 6 years. So, maybe it isn't as durable as SCIT and SLIT. I think that is a variable that has yet to be really nailed down. But in general, this is how I present it to patients, because I really feel like they often miss the compliance piece of it, and they get really, kind of down in a rabbit hole on, which therapy works the best and which study showed this and which study showed that. But if they're not going to complete the course of therapy, they're not going to get any of that efficacy. So in the end, I started with can 3 injections replace 3 years of allergy shots? Well, at Aspire, we think it's a viable alternative. We've had a really good experience with it, but there's still a lot to learn. It's clearly been demonstrated that you don't have to accumulate years and years of antigen in order to have significant benefit. So we will see. Thank you. I appreciate it. I've got a list of references if you'd like to look at any of those articles. And again, thank you very much.